This is Chapter 16, Part 1. We're going to be looking at hard tissue examination, the dentitions, developmental enamel lesions, non-carious lesions, carious lesions, fractures, and classifications. So there's three dentitions, and there's primary dentition, there's mixed, and there's permanent. So the primary dentition, of course, they have 10 teeth on the maxillary, 10 teeth on the mandibular, so they have 20 teeth, and they have no premolars. So they're A to J and K to T. Then you have mixed dentition, and then you have permanent dentition. Permanent dentition is where all the permanent teeth now have come in, and they're numbered 1 to 16 on the maxillary and 17 to 32 on the mandibular. Mixed dentition, of course, is a mixture of permanent and primary teeth. So here is mixed dentition can start happening approximately at around 6 when they lose their first baby tooth. And when we are looking at a mixed dentition in the mouth and we are evaluating each tooth for anomalies or decay or calculus or whatever, we always evaluate them separately. We look at all of the primary and then all of the permanent teeth. Instead of going one by one, whatever is next, we want to keep in mind, or we look at all the permanent and then the primary. It doesn't matter which one you do first. It matters that you are evaluating them separately so that you have all one group together. So the treatment area of the teeth. There's a difference between a clinical crown and an anatomical crown. The clinical crown is the tooth above the periodontal tissues. So here you have clearly the clinical crown because there's the tissue and it goes all the way up to the top of the tooth. So that's the clinical crown. And then you have the anatomical crown, which is the tooth covered by enamel. So they're going to the clinical crown. Over here would be the tooth above the perio tissues. And as you can see, this is a little lower. Looks like there's some recession here on this gum tissue right here. And so there's some enamel that is a little bit underneath, kind of to the CEJ. So if it has even root on it, that's considered the clinical crown, and it's what you're seeing above the gum tissues all the way to the top. So it would be longer on the clinical crown over here. The anatomical crown is still what's covered by enamel. So even if this tissue right here were, really far below, the anatomical crown is still going to be the CEJ up to the top. This clinical crown is what's showing as you're looking at it, whatever the tooth is above the periodontal tissues. So hard tissue, we are going to have a hard tissue examination procedure. They consider teeth hard tissue. It's hard tissue because your teeth are alive. It has a blood supply and a nutrient supply, a nerve supply to every single tooth. So we are going to be charting their dental restorations. There's a systematic way that we go about this, and that we'll chart all missing teeth first. I think I've kind of talked about this before. Supernumerary, which are extra teeth, and unerupted teeth that are, maybe their wisdom teeth are clearly, you can see them forming on a pano film or a radiograph, but they're just not erupted yet. So assessment, then you have an assessment of non-carious and carious lesions. There's a table in Chapter 16 and Table 16.2 on page 258 that you can look at. You're going to record carious lesions from films. Look at those, record demineralization and leaching of old restorations and any change of color on the tooth. Record any anomaly, which is anything that is different from, that's maybe not supposed to be on a perfectly healthy tooth. Any developmental enamel lesions. You can dry the teeth to be able to see better. It's really hard sometimes to see that there's a sealant or exactly what's going on when the tooth is drenched in saliva. So you let them use the suction, and then you can dry the tooth off and you can see a whole lot better. We want to look at their occlusion. When they bite down, what's the relationship between the maxillary and mandibular arches? They all have classifications. We'll have a part 2 to this chapter that will deal with occlusion. There's malocclusion. Mal before any word means something that's wrong or bad or not supposed to be that way, and so malocclusion would be occlusion that is different from normal. So there's functional occlusion, etc. We'll get into that later. But you can also have study models, and study models are when they take an impression and they build it up in stone, and then you have this model of your teeth perfectly, coming together, and that's going to enable for assessment and documentation of all the different occlusal relationships. So let's look at some, they talk about this in your book, but I've added a lot of pictures to this chapter because they used to have them in there. I know it makes the chapter slides really long, but these students were taking so much time having to Google the pictures of these and look them up, and I just decided to help you out a little bit. It makes the, and just put them in there when I can so that you can see what it's talking about. I think obviously a visual along with these long words can help you remember a little better and save you a little time. Then if you want to look further, you can kind of look through there. So we're going to go enamel dysplasia. So plasia, plasia is like a formation, and dys before anything is like it's you can have it before breathing. Dyspnea means you have difficulty breathing. It can mean abnormal. In this case, that's what it means. And so dysplasia would be abnormal formation of the enamel because it's enamel dysplasia. The cause is that there was some type of insult to the ameloblasts during tooth formation, resulting in abnormal enamel development. So what this could be is that it could be that when they say an insult to the ameloblasts are hooked with enamel. It's the cells that are there to help create the enamel development. So maybe when this is happening and those cells are all developing, the enamel, the child has, keeps spiking with a high fever. Or maybe they hit their mouth and there's some kind of trauma. Any of that is called an insult. It kind of, meaning it stops. It kind of stops those ameloblasts in their tracks for a minute until it kind of, the insult goes away or gets better, and then it goes on forming again. So that's what, and it can leave a mark on the teeth, and it's usually white. We'll get into that. So the types of abnormal formation or enamel dysplasia could be enamel hypoplasia. This is, or local enamel hypoplasia. That's where you get maybe a white spot that something happened during the formation of the enamel, and it just only shows up on a single tooth. You can have all your teeth fine and the little white spot on your tooth, it comes from inside the tooth, is just on one tooth. So that may be local hypoplasia. So hypo is less than normal and plasia is growth. So it's also, in this case, the enamel, there was less than normal growth of the enamel is what that means. So it can happen on a single tooth, or you can just have enamel hypoplasia, which happens on multiple teeth. Then you can have enamel hypocalcification. A lot of times these things look very much alike. Enamel hypocalcification is when there's also calcium involved in the development process, and there would be less than normal calcium what went into the enamel development. So this would be enamel hypocalcification, a defect. You could call it an enamel dysplasia because it's abnormal formation. And you can see here these white spots, and over here, this little white thing line right there is not supposed to be there. It is not significant of anything. So might be really, really tiny typed words, but it's a defect caused by disturbance during the mineralization or development, and there's less calcification, less than normal. It's white spotting, but it has a very smooth surface. If you put your Explorer across there, it's not going to feel rough. The tooth enamel should be very smooth, and it'll just be smooth the whole way down. It just is a white spot underneath, and just in a few places. Dental fluorosis. Fluorosis is fluoride. It's excess fluoride. It's when you have way more fluoride in your system, and it can be responsible for enamel hypoplasia and hypocalcification. It may look like white flecking on the teeth, or pitted, or even possibly have brown and brown stains. They don't have it right here, but they call it mottled stains, where it's like big, huge brown and white stains all over the teeth. So here is an example. These are all examples, different stages of enamel fluorosis. And you can see here where it's pitted. If you ran your Explorer tip across the front of this tooth, it would not feel smooth. This feels very rough, and it would go down in almost a little pit or a little hole, and it would not feel that way. This up here would feel, on this one would feel very smooth, all those, but you can see where these lines are. See, kind of like you can, so it looks like it had some kind of something was going on, and it also it was having some trauma or insults, maybe even hereditary. And then during this part right here, this wide part, it had maybe they spiked a high fever or had some kind of trauma, which was even more. But you can see along the development, and then finally it started growing again, with maybe just a hereditary issue. I just wanted to point out something here of what this would be a really great look. The gingival margin on these teeth is a really great look at inflammation, marginal inflammation covering these teeth. Those are very red. It looks like gingivitis to me. So we can go on with over here, it looks like just the tips, and it's kind of mottled. So now we're going to go to non-carious dental lesions. These are lesions and things that can happen to the teeth that don't have anything to do with eating sweets or cavities or anything else. These are just dental lesions that you're going to be seeing in your patients' mouths a lot, which is why I included the pictures for you to be able to recognize. There's enamel hypoplasia, attrition, erosion, abrasion, bruxism. So we'll go with enamel hypoplasia again, less than normal formation of growth. Disturbance in the formation of the organic enamel matrix. It has to do with enamel. And it has hard but very thin enamel, usually very pitted. It can also form with a huge deficiency of vitamin D. But you can see where these teeth, it's like they formed, they started out on the very tips not for being able to form enamel on the facial side over this dentin, and then all of a sudden it did. So it's just very different look. And you can see back here where it's not happening, you know, back here with these teeth or back here with these teeth. But it does seem to be right in the groups and the anterior. It can also be on like the first molar, maybe the canine. So these are more examples of enamel hypoplasia. You can see where here, just on, it doesn't look like the other teeth have it on this one, but these first two do. And here, the color of these teeth back in on the posteriors are fine. The lower are just really yellowed, but look at these upper two maxillary permanent molars came in very spotted. This is something, and you can tell that this, you know, exactly what level of formation that this, whatever trauma that this person's teeth went through, because it's forming just a line, and it's on the lateral and the canine also. This one probably also has it on the first molar. It kind of skips some teeth like that. But here's this tooth came in, it's kind of speckled looking over here, and this one came in with this big defect right here of enamel that just did not form a less than normal enamel formation. So here, down here, you can see on the occlusal of these molars that there's the dentin is showing through. It needed to have more enamel up here. It's less than normal. And this one doesn't have an enamel covering at all. You can see that yellow dentin, and the enamel never came up over the tooth. So enamel hypoplasia, here's where it usually goes, and there's differences, but usually this picture right here looks a lot like that one picture we just looked at, where you can see it's going in a certain line. These are over all of the mandibular teeth that can form on the cusp tips of the canines. And this one, a lot of times it's not on the laterals or the premolars or any other molars except for those first molar tips. And it's because these come in first. Okay, so when these premolars are still forming, they come in later, the permanent ones. So the child's primary first and second molar are in this spot when these are coming in. And later these come in, so it's probably why they didn't get the same kind of insult in the formation. So enamel hypoplasia types and cause or etiology. It can be hereditary. It can be systemic or environmental, nutritional, fever diseases, fluorosis, birth injury. It can be local and affect one single tooth from trauma, from a periapical inflammation around a primary tooth, can injure the adjacent permanent tooth. So the periapical, apical is the very bottom of the root, and peri is around, so it's around the very bottom of the root of the tooth, and it can have some kind of inflammation on it on the baby tooth. And so it's at a time where the permanent tooth is right underneath it, getting ready to, you know, absorb or resorb all that root tissue so it can push the baby tooth out and come in. And so a lot of times, if that's what's happening, it could affect the very incisal edges of the permanent teeth because it's also sitting up next to all of that infection so they can catch it. The appearance, hereditary, it may be brown, parts of the enamel may be missing if it's hereditary. Systemic, if it's in the system, like fever and nutritional, etc., it could be a single narrow zone. That's a disturbance for a short time. Multiple disturbances occurred over a period of time or several times if it's on more of the tooth, surface of the tooth. So the teeth affected is the first molars, incisors, and canines on the permanent tooth most of the time, although there can always be exceptions to the rule. I'll let you go ahead. Anything that says organic enamel matrix or organic matrix always has to do with the enamel hypoplasia. Okay, so this is the crown forms of enamel hypoplasia, which is just a malformation of the enamel cusps or incisal edges. You can have normal over here. This would be just the look of a normal tooth right here. These two, this is called a screwdriver, and it is rounded up here and it's completely flat like this on a like a lateral. Then you can have notched incisors where it looks like someone just clipped a little notch into the edge right in the middle of the incisor. Or you can have abnormally little. You'll have normal sized teeth and they'll be like this, and then you'll have this really small lateral, really skinny and shorter, and it's called a peg lateral. You will for sure. And sometimes those can develop on one side, and sometimes it's on both sides of your mouth, both on the maxillary. These are mainly on the maxillary teeth, these enamel hypoplasias. Then you have a normal molar over here. This is what the cusp tips of a normal molar will look like. Then they have this where it looks like little little seeds or something are on all over the enamel, the occlusal of the molar, and so they named it Mulberry molar. It kind of looks to them like a mulberry. So that's a mulberry. You can also have these can also be caused, all of that and the peg and this, from congenital syphilis. Now, if you see these, it doesn't mean for positive that this patient had congenital syphilis, but it could be, because it could be from another reason. But most of the time, the mulberry molars, etc., can be from that. Because sometimes these can be hereditary also. So this is syphilitic enamel hypoplasia because it's an abnormal growth, less than normal enamel developed over these, and it's from syphilis, and they're called Hutchinsons incisors. So this is what it would look like. And they're notched. Looks like they're notched right here. These are definitely notched, and they're even notched over here and on the lowers. So, and then the molars look like they have these deep holes where the enamel developed all over the tooth, but just not inside there. And that's significant of syphilis. This would be what an enamel mulberry molars would look like. You can have different looks. You can have this kind of a look where it looks like this pearl. The enamel is right in the middle. We don't call that an enamel pearl. There is such a thing as an enamel pearl when you look on a radiograph, which you'll go through in your radiography class. But this is more like a mulberry tooth that can have even more of these little formulations. They're hard. they're all hard, and this is dentin underneath. That's going to be hard. So it's not like it's this soft mass. It's very hard, and it has nothing to do with decay. So these are Noncarious. Here's a peg lateral. This is also called microdontia. If you have a test question and it says, which of these teeth can be called microdontic or has microdontia? Dontia, dontal, dontia, there's some other words that I just can't think of at the moment, all mean teeth. And micro, of course, is very small. So they call this microdontia on this tooth because it's smaller than the rest. If you had one that was, bigger than it should be next to the rest, it would be macrodontia. So this is possibly syphilitic, possibly idiopathic. Something that is idiopathic is the cause is unknown. They don't know why. So it's called idiopathic. But you can see here where here is a normal lateral, and this is kind of egg shape. You will see some of that. So here's microdontia. There's gemination, which is splitting a tooth germ, a dens and dente, which means a tooth within a tooth, dilacerations, they're curved root tips, and Talon cusps. And I picked out some things that you could possibly have on boards that you'll need to pick out in radiographs on your patients, even though your chapter didn't completely go. The last year's worth of chapters included some of these in there, and I just wanted you to be able to know what they were when you see them. So this is dens and dente. It means a tooth within a tooth. You can see here, there's a tooth bud right here in the middle of this other tooth. It's just kind of weird. And here, this is what it looks like on a radiograph. You can see this, spot right there. This also has an abscess down here. You can see that big dark around the periapical of the root. But sometimes this tooth within a tooth, it has to do with the splitting, the gemination and the splitting of tooth cells. And this particular one has the tooth and it's growing on the back of another tooth. And so this is all attached. It's not two separate teeth. It's two separate, like this looks more like an incisal edge, and this looks more like an occlusal edge, that little tiny one. But it would be hard to clean in here. This is probably a prime area for, it looks like it has stain in it and future decay. But this just happened on one tooth, and it can be a tooth within a tooth. So this is gemination. It's a large tooth from big, it's way larger. It's like this whole thing is one tooth. Okay, so it's when the splitting of a single tooth germ, and it tried to form two teeth, but didn't quite make it. So it formed two incisal edges, not just the whole thing right here. That can happen. This is dilaceration. You'll see this probably pretty often in if you're going to be having, like in private practice, 8 patients a day. You'll see it maybe on at least one of the patients during the day if you're taking radiographs. So it looks like the handle of a umbrella, and it can't just kind of curves up. It can curve to the side, but a lot of them will be like a little handle like this. It's from trauma during tooth formation, and so the root, they call it dilacerated root when anytime it curves to any side. So let's go with hyperdontia. Dontia means teeth, of course, and so hyper is more than usual teeth. You have supernumerary and you have supplemental, and you have what they call mesiodens. The supernumerary they use that word when there's extra teeth of an abnormal shape. So they have all 32 teeth, and maybe they have 2 extra canines. Okay, they look exactly like the other thing. I mean, they don't look exactly like the other canine. There will be a weird shape, maybe smaller, maybe it's microdontia or macrodontia, but they're extra teeth that you may have. And you'll come across that every once in a while, but you'll have someone, especially on the lower anteriors, that may have, instead of having two laterals on this, on each side of their maxillary teeth, they'll have like 4 or maybe 3. Maybe there's one extra one on one side, but not the other. And so you need to be, it can throw you off on your counting. Then you have mesiodens. Mesiodens is a supernumerary. It's an extra tooth of an abnormal shape in the maxillary anterior midline. It is possible. I have seen it. Even though this is kind of the definition, I have seen them on the mandibular, but most of the time they're going to be in the midline of the maxillary, and I'll show you pictures. This is mesiodens. It's also called more than normal teeth, so it's hyperdontia, and this is mesiodens because this is the mesial of this tooth, this is the mesial of that tooth. And so it's on the mesials in between the centrals. Okay, so that's where they get, and the dens is a tooth. So they have a lot of different words. Excuse me for that. So this grows, and it's usually kind of pointed or rounded. It's of a different shape, and it's just this extra tooth that shows up. So this is mostly where we see them, as mesiodens means in the middle. And so it's an extra tooth on their maxillary that just shows up right there, and they usually wind up getting it pulled. If you take an x-ray of 2 teeth, you can see up here that there is an extra tooth that's not erupted, but is just up there. You can see here is these are very maladjusted. You can see that there is a tooth right here. These look like the centrals, and then this looks like something in the middle and something back here, and then it goes on to their laterals and their canines, and then it looks like they've got matching premolars and molars, but this is crowded and has extra teeth right in the middle. This is a person whose permanent teeth never came in. They either never had the tooth buds to begin with, and so they kept there were no permanent teeth to push the baby teeth or deciduous teeth out. So you will see something that is looking like this. So in this case, what it looked like is that they came in to the side, because this looks like a central and this looks like a central. So they must have come in to the side, and these they weren't positioned right above the baby teeth, and they moved over to the side. So this is hyperdontia. Also, this person has a central and a central, and this looks almost like a molar turned to the side. Kind of a weird looking shape of teeth right there, and it just came right in between their centrals. So this is examples of supernumerary or supplemental teeth, and I brought this on here to show you because there certainly are cases to where there's been people who have had a row of like baby teeth, like a row of baby teeth, they kind of call them shark teeth, behind their maxillary, but this much, I mean, looks very fake to me, mostly because some of these teeth, if you were to look really carefully, it looks like it was like, I don't know what they did, photoshopped or something in there, because they're the exact same tooth in every single way, just turned to the side on some of these. They look awfully alike. So what I'm saying is that you can pull this up on the internet And when people find out that you're a hygienist, they may, see pictures like this, and they're going to come ask you at their appointment, is this true? Is this possible? Well, yes, it is possible to have a lot of extra teeth come in. It's very rare, but it is possible. But you have to look at this and say, however, be very evidence-based in your answer that some of this looks very fake. And they put in here a radiograph of all these extra teeth. And I don't know, these all seem to be in the middle. I don't know what that must look like in person. I mean, it just doesn't look right. So you're going to have to be the one to discern that. Here's an example. Some babies are born with teeth. They'll have little teeth. You can see these little tiny baby teeth on the bottom. It has like already 2 centrals. So they may ask you that. Is it possible? Can babies be born with teeth? Well, it's rare, but yes, they can. So this is what's called a talon cusp because it looks like a talon. This grows on the back of this tooth. So they're not like 2 separate teeth. Well, they were 2 separate looking teeth that are fused together. So it looks like a talon, and that's how it got its name. These are not quite as pointed. One is like really, really wide back here. This is very rounded over here, but they're still called talon cusps. So now we're going to go to attrition. Attrition is a wearing away from tooth to tooth contact. And attrition, you'll look at the incisal edges and the occlusal edges of somebody's teeth, or even proximal in between. Age factor, attrition can increase with age, where older folk, especially in their 70s and 80s, may have a lot of wearing away from tooth-to-tooth contact from their whole life. So this is where the teeth are not spaced. I mean, they're parafunctional in that they're a little maybe outside. Their bite isn't quite normal, or their bite, it could be perfect, but their jaws are just slightly tilted to one side or the other, and so they wear one side, their teeth close on one side just a couple millimeters sooner than the other side, and over the years those teeth are coming together in a way that they were not meant to be, and they just wear away the surface of the tooth. So attrition is another way of another more serious form is bruxism. Bruxism is a type of attrition. It's the person, you can have a sleep or an awake bruxism. This is the person has a lot of tension on the occlusal surface. They grind their teeth and grind their teeth at night when they're not even aware of it, and could definitely use a night guard, so that over the years it just wears it away, so little bits at a time. But you just all of a sudden, 15 or 20 years down the road, they can have worn away a lot of the surface of their tooth. So some people do that when they're awake, and maybe they have to try to get treatment for trying to stop this bruxism while they're awake, and get some help with nervousness and etc. So it's the wearing of a surface on each other, and it's what will make is when they're wearing like that are small, they look like polished facets, they call them facets, on the cusp tip or ridge of a molar or incisal edge. So this is what it can look like right here. Pulp chambers and canals may be super thin due to the formation of secondary dentin. So we have enamel covering the dentin, right? And when a tooth is getting a lot of abrasion or being kind of assaulted in a way, and it's being worn, the enamel's being worn away, your body tries to go to protect that particular spot, and so it will make thicker and thicker dentin to help protect. It's trying to protect the nerve of that tooth in the pulp, so the tooth doesn't die, and so it will make it really thick, which on a X-ray is going to make your pulp chamber really teeny thin. You'll see them sometimes on, if you have a patient that has this, you can look at their radiographs and see how teeny tiny their pulp chambers are. It's usually on the top after it's worn like this. It looks like there's a little indentation on the top, little slits. That's usually brown or really, really dark, kind of a yellowish, goldish, dull gold look. And that's because stain has gotten in there, and it's taking on the form of different things that they are, coffee, or foods that they're eating or smoking or something. It's the dentin usually shows us this kind of brownish ring that's inside the tooth. So here we go to some major, this person has been bruxing a lot, and I can see over here that they're minus some teeth. And most likely it's if it's the same on the upper, all their teeth are probably sliding around on each other, trying to grind and when they're chewing. And this is what it can look like. So let's go to erosion, is another type of enamel dysplasia that doesn't have anything to do with cavities. And its erosion is a loss of tooth surface by a chemical process. So it doesn't involve bacteria or anything like that. It's chemical, mainly acidic things. It's on the facial or lingual surfaces, depending on the cause, and it usually involves more than one tooth. Usually involves a group of them, or even 6 or 8 on the lingual. The cause, chronic vomiting, affects the linguals. You've got chronically, got that acidic throw up coming and hitting the teeth a lot. It can also be diet on the facial surfaces. There are some people, and especially some cultures in the islands and tropical places, that will just chew on lemons or limes all day long. And so they've got that acidic fruit on their teeth. And that can cause, that chemical can cause that look. So it can be smooth, shallow, hard, shiny, saucer-like depressions, all the way to a deep wedge and lots of grooves. So this is acidic right here. You can see that erosion. This is tooth erosion due to bulimia. Right here, you can see the facials look fine, but you can see these white, that's where the enamel was, and it's all worn off, and you can see a lot of dentin there because it's constantly going over these teeth. These can be acid erosion and a little bit of on these up on the top here, probably bruxism. These are probably several things rolled into one. So, and toothbrushing, too hard of toothbrushing. This can be acid erosion up here. You can see they've got a recession really badly up here, and then it's kind of notched out a little bit, and this is eroded on the root surface. You can see all of those close to the root. So, abrasion, mechanical wearing away of a tooth surface by forces other than chewing. Okay, so we had attrition, and that's from tooth to tooth contact. A good way to remember the difference between attrition and abrasion is attrition has two T's in it, and the definition is tooth to tooth abrasion. So think of it that way. The two T's are tooth to tooth, or T to T. Okay, so abrasion is a mechanical wearing away by forces other than grinding and chewing that together. So abrasion is exposed roots or incisal or occlusal surface. The cause can be abrasive agent like vigorous toothbrushing or tacks or pins, and held by carpenters or seamstresses. People that used to smoke pipes all the time when they got older, it was really big decades and decades ago for men to be chewing on a pipe, and they would have it in their mouth and kind of chew, couldn't even help but kind of chew on it in between their teeth, and it was a mechanical, after years of wearing away, that could look like that. Seamstresses that hold pins, straight pins in their teeth at the same spot all the time, and eventually through their career can wear little notches on the incisal edges. Hairstylists used to have bobby pins and put them all in their mouth and take them out and be putting them in someone's hair. So the cause, we just went over. The appearance is like a V-shaped wedge with hard, shiny surface. It's called abfraction. So you'll see a picture in a minute. A smooth, shiny surface on exposed dentin, and then it will extend into the dentin. So this is another name for abfraction due to rigorous toothbrushing or flexion from pressure. So you can see, you'll see this in there. Now most of the time they have to have recession, so already the gum tissue is way down here. You know, it may go up like that. And so you'll feel this, and it looks like someone just took a big notch. It's just this weirdest thing looking, and it can be kind of pointy like that, or it can be rounded like this. And so it's a wearing away of that tooth surface. Now, a lot of times this is due to a hard toothbrush and too hard a pressure when you are brushing, and year after year after year after year, it can make this kind of a notch that's called abfraction. You can also happen because of maybe the tooth that is opposing this is supposed to kind of fit in like this, and maybe it doesn't. Maybe it's directly where the cusp tips are going like this, and so every time they close, instead of fitting like it's supposed to fit, it's constantly having this force come down on it, and it's constant through their life. And so little rods break off in here because of flexion. It's kind of pushing the tooth down and hitting the tooth, and it starts to weaken on one side or the other. This is what it looks like in real life. You can see these this recession, and you can see this just looks like there's this notch thing that's been taken out of the top of the tooth. That's abfraction. This person has recession and abfraction. So fractured teeth causes are trauma, hypomaturation. Hypomaturation is less than normal maturing of the tooth. It occurs in the very last stages of mineralization and results in really thin enamel that fractures easily. And so these type of people can be prone to their teeth fracturing. This can be also from trauma. You can, sports, falling flat, little kids especially falling on the cement as they are skating, etc. So it can be due to trauma, or it could be due to They don't have to hit it very hard before it breaks off due to this hypomaturation and enamel being too thin. You can have horizontal fracture, you can have diagonal or vertical. One thing that you can see when there's an issue somehow with a tooth, a good telltale sign was you'll look at a radiograph and you will see that the black line around the tooth, which is the periodontal ligament, is really wide. You know, it's much wider than this thin little line. And so that's what's happening too, is the periodontal ligament is widening out, trying to be stronger because something is either pressure or something is kind of going on with that tooth, and it's trying to protect it. Okay, so we all know what a fractured tooth looks like. But the World Health Organization, which is WHO, has fracture classifications. I remember this being in review books for boards. This will give all the different types of root fractures. They have an enamel fracture, which is just at the CEJ, and it's just a little bit, like, let's see, the little bit of this is, because it's just involving the enamel. So this is enamel, this darker area right here is the dentin, and this being the pulp inside the root. So on B, the fracture would, if it's a fracture class B, the fracture has done the enamel and hit into part of the dentin. So on C, you've got the crown or enamel and dentin, and it's got part of the root, the pulp. So this is going to be a different type of, this one's definitely going to need a root canal and a crown, because they'll have to take that root canal, root out. But at any rate, D is a fracture of the crown and root near the neck of the tooth. So it's crown, crown of the tooth and part of the root, and it's close to the neck, close to the margins here. This root fracture involves even cementum and dentin and pulp. This is a fracture that is maybe fracturing here. It's fractured like horizontally. You can have fractures down a tooth. I've seen x-rays to where you see this extra line right here that goes all the way down to the root of the tooth, and I'm like, what is that? And it's a root fracture, but it's going kind of down like that. So dental caries, it's microorganisms, the carbohydrates, and a susceptible tooth surface. Those, I know that. Those are the three things that you have to have in order to have decay or a carie. Biofilm is not a requirement for decay, oddly enough. We all think you just get the biofilm off and you'll be ready, you won't have any dental caries, but it's not that simple. The biofilm, however, does contain numerous types of acid-forming bacteria, such as Streptococcus mutans and Lactobacillus, and even Candidiasis. But these two, I would know these for sure. You'll go more in depth when you get into periodontology class next term. But Streptococcus mutans and Lactobacillus are the main two that have to do with they're acid-forming bacteria that has to do with dental caries. I would tuck that away for sure. So you don't have to have biofilm to have decay, but what you do have to have are those three things. You have to have some type of microorganisms. You have to be drinking or eating a lot of carbohydrates, and you have to have a susceptible tooth surface. So to make it a susceptible tooth surface, if it's a tooth that's never being taken care of, it's more likely it has tons of biofilm. The problem with the biofilm is that it can contribute to decay, but it's not a requirement. You could have these other things and very little biofilm and still have make decay. So if there's also, they used to think, and they thought up until just a year or so ago, they have thought that the Streptococcus mutans and lactobacillus are the main reasons. Now they've come, the new theory is thought to be the imbalance of oral microbiomes are more responsible for decay than the Streptococcus mutans and lactobacillus, although they obviously are hugely important in their contribution to dental caries. But the imbalance of oral microbiomes is the theory, in that when a tooth is not being taken care of, it's going to have so many oral microbiomes and on it all the time, and there's no balance anymore. And so then you can start having, that would be a susceptible tooth surface, and you could start having caries that way. So we're going to move on to classifications. GV Black, and we go, all the dental industry goes by Black's classification for restorations and for decay. So it's the nomenclature, it's a certain nomenclature by surfaces. So here is Black's classification, is that the appearance of a tooth, a class 1, could have, or when you see cavities in the on an occlusal surface of a molar, and it could also be on the lingual surface of an anterior, mainly the maxillary, because you can see this cingulum right there. So if a decay, it could be little, it could be big, it doesn't matter. If there are caries either in this spot or here, you'd call that patient has a class 1 decay. And let's say that they had a filling here or a filling here. You would say they have a class 1 filling on tooth number 19 on the occlusal. Okay, and that's a class 1 filling on maybe number 7. Okay, so that could be that. A class 2 is when you have decay on the interproximal, and it could also be on this side. Okay, it could be on both of them. It could be on just one or the other, but it is the proximal surfaces of premolars and molars. Okay, just premolars and molars. So a class 3 would be, class 3 and 4 mainly have to do with the anteriors. A class 3 is when you have proximal surface there, and it does not involve this angle right here, these angles. It's just here or here on the proximal surfaces. A class 4 is when you have decay, and it does involve this angle. So they need to have even this a little more. So this is even up in the dentin, but it could be up there, or it could be anywhere around, you know, that corner or all the way across. But it has like 2 planes. It has this plane and that plane. Where this just doesn't involve that. It's anything higher than this. Class 5 is anything at the cervical part of the tooth, which is up by the gum line. So it can be itty bitty, it can be big, it can even be bigger, like this. So you call that a class 5. Or on an anterior, see how it's up there? Some people just have a filling that's about that big right there because they have a class 5 decay. So now they have a class 5 filling. And so if someone says to you, would you please mark number 1, 2, and 3 molars with a class 5 on the buccal? So you know that it has to be on the buccal side or the facial side, and it has to be up there. It doesn't matter really the size. It just matters that they have to have treatment there for the dentist to know. So this is a way to communicate, which is why they call it nomenclature. It has its own little language here. Okay, so then we go to a class 6. A class 6 is cavities on the incisal edges of anterior teeth. So it can be on the incisal edge there and the cusp tip of a posterior tooth. So this is it would be just, and it's weird, sometimes you won't see anything wrong with the tooth and you see this literally, it will look like this little black hole. And you're like, how did that happen? But it's easy to see. Usually their toothbrush is going over here and they're doing floss and everything else, and just never getting that cusp tip. Usually we don't have to worry because the cusp tips are hitting the food so much and everything, but it is important not to forget the cusp tips of our teeth. So this is Black's classification, and you'll have hopefully I've already handed them out to you. If not, will or put them on the modules for you to print, because I would keep this definitely in your folder for the clinic. So we've talked about this before, so I'm going to let you go over how these are put together and what comes first, like mesial or distal, and then occlusal, and then buccal will always precede lingual, and you can see how they put these words together. On simple caries, one surface, compound caries that has two surfaces that run together, and more than two surfaces that run together. So I'll let you kind of go over that. Let's go on to different types of decay. This is how decay kind of happens. At first, on phase 1, you have what they call an incipient lesion, or this is called a white spot lesion, or it's also called it's demineralization. The minerals are being taken out of the middle of that tooth. Now, if you ran your Explorer across that spot, it would still be hard. It wouldn't be real soft or anything at this point, but it's usually real hard like enamel. You don't want to push on those spots because maybe it has been going for a while, and maybe it will kind of cave in. But usually at the very beginning, an incipient means that it's newly formed. It's tiny and it's newly formed. It's just on the surface of the enamel. It has not gone deep, because sometimes with the toothpaste that we have that can remineralize those areas and close them if they are really at the surface and newly formed. Sometimes that can happen, and then they won't develop into decay. This is phase 2 and 3, and I just put this on to kind of show you what that means. You can see on this enamel, you can see on this picture as well, see all these tubules that go from the outer surface into the dentin. Well, the dentin here, and so you can see them here. Well, the dentin here has those same things, has tubules. Okay, and so when there is decay, like on the outer surface, and in this decay, it decayed this, and it can kind of very quickly go through these tubules to the dentin, which then can also pretty quickly go through. We're not talking a day, but I'm just saying that if it's not treated, it can kind of travel down to the pulp, and then you've got an issue. So a phase 2 would be breakdown of enamel over the demineralization. So what happens is, let's say that this was enamel. The inside these tubules also, it's kind of like a honeycomb. Okay, but they're all real tight together. and it forms something that's really strong in there. But when you have demineralization on the outside, it's like sucking all these minerals out, and these real tight little places become looser, almost like sponge, and like these holes in different places, or a honeycomb pattern. And so that's why they say that decay happens from within, and then it will cave it kind of goes outward also and caves in the enamel surface. So it can leach out the minerals. These become more honeycomb and wider on the inside, so that if you put your Explorer right here, at first these are still real tight. And then as it is there and it's a spot that they just cannot, it constantly has biofilm on it with carbohydrates, and even if it doesn't have biofilm, it could have the carbohydrates and microorganisms, and so they keep leaching out more and more. This becomes, has a lot more holes, and so if you put your Explorer or instrument there, this will just all cave in because it's not tight anymore. And then when it caves in, you have nothing there. You have just a big hole, and then the decay will start to go inward. So sometimes the other thing that I want to point out here is that right here in the pits and fissures of the pits of the occlusal part of a molar or premolar, it can look perfectly fine all the way up here, and then there can be this little, the pit. And this pit can be like really, it could be like really long and really skinny like this and on up to there, to where sometimes stain will get in there, and that's why you can't get it out. It's so deep. But if it is decay, you can have this little tiny spot up here that looks like, oh, that's just a little tiny bit of decay. And what happens is that it can go like this and form a much wider amount of decay underneath. Or you can have a big wide piece of decay like this, and maybe it's just real shallow. It's only going to there. So we have to be careful. Phase 3 is when it spreads into the dentin and or the pulp. And those are the phases. So there's several types of dental caries, but these dental caries are by location. I would know this. It's pit and fissure, which is one type, and then the smooth surface. So the pit and fissure obviously has to be over molars and premolars on the occlusal surface. And a smooth surface is proximal surfaces protected near contact area, cervical thirds of teeth, and other difficult to clean areas. So it could be these smooth surfaces that just on the buccal side just has this little, it just gets decay. So these are some additional types. You can have primary, which is caries, which is also called initial caries. And early lesion may be called incipient caries. It's usually on a surface that was not previously affected. When we're going to talk about when we're in clinic with patients, is that recurrent decay or initial decay? So was it the first piece of decay, or is it recurrent? And recurrent is on a surface adjacent, just next to a restoration, and it's sometimes really hard to see on radiograph. But this recurrent decay means that, let's say that someone had an amalgam occlusal amalgam filling on the occlusal of the tooth, and it's old and everything, and all of a sudden on the edge of one of the amalgam on the actual tooth surface, there starts to be another decay. That's called secondary decay or recurrent, because it's occurring again on kind of the same spot. Arrested decay is when it just stops. You can stop it from progressing any further. Sometimes some of these toothpastes can take, well, just like that, I was saying some of the toothpaste can kind of remineralize and arrest that decay from going any further. It means stop it, and it doesn't get better, possibly, but it doesn't get any worse. Maybe it gets a little better. Rampant. Rampant is sudden, rapidly, caries that rapidly spreads into the pulp. It usually is associated with children, but it could be adolescents or when someone has dry mouth. They have xerostomia, as lack of saliva. This would be early childhood rampant caries. So sometimes there are younger teeth even than this because they've been bottle fed, and they put them to bed with a bottle, or sometimes when they're teething or just to get a baby to go to bed, they would put honey on a pacifier back in the day, or they would put syrup or something on there and then put the kid to sleep. So this is our milk bottle mouth is kind of sometimes what they would call this, but this is rampant decay. It's almost over every tooth. So the cause, nursing bottle with milk or sweetened beverage when sleeping or at will breastfeeding, and when you're not taking care of their teeth afterwards. Microbiology, here's the Mr. Streptococcus mutans and lactobacillus again, that's in the biofilm. The biofilm isn't necessarily what's going to cause the decay, but it's the microorganisms inside there. So effects, the maxillary anterior teeth and primary molars are the first to be affected. You can recognize it at like 6 months old, even at their first appointment. This is a picture of root caries. When you look at different types of caries that you can see on a film, and you can see this is very early root caries right there. This is what it's going to look like outwards, and it looks like there's some erosion here. Looks like there might be some adfraction up here. Definite recession. And then the roots are showing, and you can get root caries much faster than you can get enamel caries. Enamel is harder than bone. It's the hardest thing in your body. And the dentin is hard, but not as hard as enamel, and so it's a little softer, even though it's going to feel hard to you. It can form root caries really quickly. But in order to have root caries, you have to have recession. Your gingiva has to be receded so that your roots are exposed. So it's at the CEJ, cementum is thin, and that's what's over your dentin. And so that cementum is thin and it's very soon destroyed. The dentin is then invaded, and root caries increases with age due to increased recession in older folk. So root caries need mildly acidic environment. They need a 6.0 to a 6.7 pH. Normal pH of saliva is 7.4, so it's a little acidic, but not hugely acidic. It's very mild, and that's all that they need for the pH to be in order to get decay. And so a soft progressive lesion of cementum and dentin involving bacterial invasion. The effects, it's directly related to fluoride in the water. Communities with a lifelong fluoride have significantly fewer root caries. Caries in general, but it's in particular root caries. The clinical recognition, you can see it. Active lesions are soft, leathery. They could be hard because maybe secondary dentin has formed over that softer dentin trying to protect the tooth. So these are root caries in stages. You have stage 1 is the formation of root surface lesion at recession. So this is a normal tooth right here. This is the very, very beginning. That dark area is the very beginning right at the CEJ and near it. And so initially you will have light to dark brown. It takes on stain at or below the CEJ, and there's no cavity. Usually it's just a stain. Then it goes into another moderate to extensive area where it's a discolored area and it does have a decay there, maybe kind of leathery feeling, and then it can go all the way around the root. So clinical examination of the teeth, you want to be able to, of the lesions, visual and exploratory examination of the smooth surfaces. We don't do too much on pits and fissures anymore. Used to stick the explorer in a pit, and if it really stuck hard, that meant that there was cavity starting there. Well, we don't do that anymore, and we'll go into that when we start going through instruments. Radiographic examination, you can determine decay if there's root resorption, an abscess, bone loss, and overhangs, among other things, when we're examining the teeth that we can't see. Visually, we can always look at a radiograph. So this would be root resorption. If people were always asking me, and I finally put some pictures in here. Here's your roots, and this root is resorbing. Here's the casing for the root, but the actual root is, something's causing that root to resorb. Okay, and look at this root, how much of that root has resorbed back into the system. Here, there's something's causing these to resorb. This is resorbing. It looks really strange down there. This just looks like a big, huge decay, that it was root decay right there, but even these look like they're resorbing just a little bit. So that's what happens when you're here would be a baby tooth, and their premolar is coming in, and what happens is when a tooth pushes against another tooth, it starts resorbing the roots, and it will resorb it all the way up to here, and then it just kind of finally, this one comes out, and you put it under your pillow for the tooth fairy, and then maybe right away or in the next week, the next few days, you'll see the top of this come through, but these usually help push the baby teeth out, and it resorbs those roots. This one looks like it's just a supernumerary tooth, or a tooth that never came in its right spot. It's the way that it's laying up here, and since it's next to that tooth and pushing on it, it is, or even contacting it, it's resorbing all these maxillary teeth. Well, that's not good. This is a nasopalatine cyst that's resorbing these roots. And here's just big decay right through there. This is a goner right through the pulp. So this is what happens on an impacted tooth. I put this in because this is the idea of the same thing. This tooth has to make this curvature upwards like this in this area, and it just didn't make the curve, and it's hitting into this tooth, and it's never, maybe all you see is this little tip above the gum line, and on a radiograph you can see that it's butting into this tooth right here, and it's resorbing all this area right there. So also, kind of to end this chapter, they talked about the types of pulp vitality testing. You need to really check, because pulp vitality testing, electrical anyway, is not legal in every state for a hygienist to do. Most of the time a dentist is doing that, but the reason they do it is to assess for pain. Like let's say that little Jimmy comes in because he got hit with a basketball. It wasn't enough to knock his tooth out, but his tooth is really hurting. It's super swollen. They're afraid maybe something's going to happen to it. They rush him to a dentist. They take an x-ray and they try to see if anything is wrong, and the dentist maybe goes, well, I don't see anything. What they can try to do is they can put the different types of pulp vitality, means life. So they're trying to check for the life to see if the pulp is still alive. And usually it's done by the dentist, and it can be done in different ways. You can have a thermal, which is through heat and cold, which they can put on there. You can have electrical pulp testing, but this is something, these are two different types of testing, and depending upon what tooth it is. And here's some testing that way. So this is the end of chapter 16 of part 1.